Hello and welcome. I'm Greg Meakin, Director and co-founder of Welltech Medical. Recently, we hosted a seminar with the focus being OCD, and this was led by our clinical director and experienced CAMHS practitioner, Dr. Nishchint Warikoo. Parents were invited to submit questions before the seminar and indeed during. This made it interactive and useful for all participants, and we'll be offering other seminars online in the near future. We'll publish the focus topics in advance and invite you to register if you'd like to take part. We hope these experiences will advise and support parents and adults. I invite you to join more of these opportunities in future and look forward to seeing you. Thank you.
It usually starts around puberty. So we're talking of 8 to 12 years of age. Before that, it's uncommon to present, but after that, yes, you can see young people having this problem. As we all are aware, it can be quite distressing, and it can significantly interfere with the young person's everyday life. That is, their being able to enjoy anything, their ability to go to school or do things on the right time, finishing their homework, or just the common things that children do is go out and play with friends. If it's severe OCD, then they might find it very difficult to do. But the good news is there is treatment which can help keep it under control. Often parents would ask what causes it. And to be honest, there isn't enough research to tell us what causes it. The main cause of OCD is quite not certain at this stage. But there's lots of research which has been done on OCD. And one of the key things that we know is an imbalance of a brain chemical called serotonin. So once that's got a bit of an imbalance, that can lead to OCD. And hence the medical treatment is almost focused on that aspect of it. Then parents would say whether there's a genetic reason for it, or is it something that happens to us which could lead to OCD. Yes, there is a genetic link to it. If there is someone in the family who has OCD or has tics or Tourette's, there is a chance, there's a higher chance of the young person having OCD. The other which is an environmental factor, is sometimes young people might get obsessive and compulsive symptoms after catching a cold or having a cough. So that's another form of OCD, which often is referred as PANDAS, which means pediatric autoimmune neuropsychiatric disorders associated with streptococcal infection. Sorry for that long name, but that's the name that has been given to it. And it's often the difference in this form and the other form of OCD is that in PANDAS, the symptoms are quite dramatic and happen quite quickly and usually are associated with a recent infection. So that's what differentiates it mainly with the normal OCD. The OCD can also start when a young person is going through a difficult time in their life, or they have had a traumatic accident that can also make it come up. That's not always the cause of it. It's possible that the young person already has a genetic tendency towards having OCD, and then these stressful events would make it more obvious. What are obsessions? So obsessions are an unwanted and an unpleasant thought, image, or an urge. So the key thing is they're unwanted and they're unpleasant. And these thoughts or urges, they repeatedly enter the mind of the young person, even though they don't want it. And when they enter, they also are very annoying, they can be unpleasant, and they can be very distressing to the young person. And the young person actually wants it to go away, but it keeps on coming back to them repeatedly. So this aspect of it, A, it's repetitively coming back to the mind, B, it's being so annoying, and C, it's causing anxiety, can be a major distressing factor for the young person. Now, obsessions can be of different types, so a young person might have an obsession about their hands getting dirty, or they're catching disease. They might worry about some harm coming to them or to someone else. Sometimes there might be a reason for worrying about that, but still it's not proportionate to the cause of that anxiety. So yes, children would worry that if they have touched something dirty, then they might catch an infection. But this is more severe than the normal worry or normal anxiety around catching infection. And the obsessions then lead to severe anxiety or feeling of discomfort. What that then leads to is an urge from the child to put it right. So the obsessions come, they cause anxiety, and the child then feels the need of doing something to put it right. And that's where the compulsions come in. So first there are obsessions, which will lead to anxiety, and then compulsions, which are almost done to relieve this anxiety, which is coming from obsessions. So the compulsions, they can be in form of repetitive behaviors. So the child might be doing the same things again and again, which other people can see, but this can also be in form of mental acts. So in their mind, they might be repeating a word or a phrase because that's what they feel would help with the anxiety. So the young person has this urge to do it, and with the hope almost that it will take away the anxiety, which has been caused by the obsessional thoughts. But unfortunately, it doesn't happen. And these behaviors, these rituals, or these mental acts are not necessarily something the child might want to do or enjoys doing it. So it's key to highlight that here, because in children with Asperger's or autism, they might also have repeated rituals, behaviors which they do repeatedly. But in that case, they might be enjoying it, or it might be a way of soothing them. Whereas in OCD, these behaviors are not helping actually. They are repetitive and the young person doesn't actually want to do them. So for example, if a young person is having obsessive thoughts, they might feel turning the light on and off 20 times would make the worry go away, or doing that might take away the bad thing that might happen to them. So that's what these compulsions are. Other compulsions that young person might have is washing their hands. They might check things. They might think certain thoughts in their mind, as I mentioned earlier, and they might keep things in a particular order on a desk or in their room. Their room might be very tidy, which is not common in a teenager, let's say, but you will find a teenager with a very tidy room, and that's possibly in this case because of the rituals that they have to do. Now, obsessions themselves, or rituals or behaviors which look like rituals themselves, do not always constitute obsessive compulsive disorder as such, because there are phases in the development of a child where it's normal to have some kind of obsessions or some kind of repetitive behaviors, but it becomes problematic when the young person has the obsessions and compulsions to the extent that they are impacting their normal day-to-day activity and their ability to enjoy life. When it gets to that distressing stage, then we would call it OCD. So that's general overview of OCD. What are the treatments available for OCD? There are two key treatments. One is the psychological treatments, and the second one is medication. From the psychological treatment, the most evidence-based treatment is cognitive behavioral therapy, and a form of it which is called exposure and response prevention. So it's based on a principle that anxiety leads to obsessional thoughts, and as we earlier talked about it, that obsessional thoughts create anxiety, which then leads to rituals. And young people who have OCD almost have a strong belief that if they do rituals, that would help reduce the anxiety. But unfortunately, it doesn't do that. And they get into this vicious circle of keeping on doing the rituals again and again and again. And the rituals get more and more complex. So it might start with the child doing some ritual, either in their mind or do it in a private way. And then it goes on, it becomes quite obvious to everyone. And then it can extend to not only them, but to their friends, to their family. And in an extreme case, which I had seen a long time back of a complex OCD, there the young person was making her cat do a ritual for her, and the family was taking part in it. And it just highlights the extent of anxiety that OCD can bring, not only in the young person, but in the family around them. So exposure and response prevention, which is part of, as I said, a CBT form. In this, the young person is first given information, and almost everything is explained. That is the obsessional thoughts, what they are, what they cause anxiety, and then rituals come up, and also explaining that the rituals are not helping them, even though they feel they are. So what do? They slowly expose them in a stepwise manner to the obsession, the anxiety provoking situation. And once they have exposed them to that, then instead of the young person doing a ritual, they are encouraged not to do it. But because there is anxiety, they're also given some relaxation techniques to reduce the anxiety, so that the young person is exposed a bit to the anxiety provoking thing, but at the same time, then they are helped to relax, so that next time they can do a bit more of it or take more step forward in that direction. So that's the exposure and response prevention. It involves usually the therapist doing it with the young person, but often a family member is also encouraged to join in, so that they can help the young person, help them reduce the anxiety. And because most of this is done at home, it's always helpful to have a family member as part of the treatment team, almost, if we say that. So that's the psychological aspect of it, or psychological therapies. Sometimes the young person has such severe OCD, it's so distressing that they're not able to engage in a psychological therapy. In such case, we have to first start medication. As I mentioned earlier, serotonin is the chemical which is less in the brain, or there's an imbalance which can lead to OCD. Hence, a medicine which comes from a family called SSRIs, which is fluoxetine and sertraline. Those medicines are given to the young person. They help to balance out the chemical in the brain, and that then enables the young person to participate in any kind of psychological therapy. Often the research, lots of research suggests that it is a good idea to try both of them at the same time, but it depends on the severity of OCD, because if it's not that severe, if the child can take part in the therapies, then that's the first thing that should be done. But obviously, if it's more complex, if there's high risk, then it's a good idea to start them on medication and at the same time introduce CBT. The key thing to remind ourselves is the medication works when it's taken, whereas the techniques and the skills of relaxation and CBT approach, they will stay with the child forever. And hence, if they do have stressful times in the future, they can use those skills to help them get out of these situations. Thanks a lot to everyone who has sent me the questions for this presentation. And again, I would say most of the questions are asked by many parents, because there is a pattern to it, and lots of young people present with similar problems. And in a way, it's helpful to know that, because then we know other children or other families have faced the same problems, and they have come out of it with the right support. That gives some reassurance to us as well as parents that we can manage it. Is what to say when to the child when they are stuck in a ritual, or how to calm them down when they become distressed. So this is a very good question, and I think a lot depends on the severity of the OCD. But whatever the level is, and whatever the support is in place, there are three key things that the parents can keep in mind. One of them is, the first one is to understand. Second is to be non-judgmental. And third is to be calm themselves and help the child to feel calm. First thing is understanding. OCD is something which comes in, and when it comes in, the parents would obviously feel anxious about it, because this is not what they have seen. And the second thing is, it can generate so much anxiety in their child that they want to do all they can to do that. And the best thing that a parent can do is to gain as much information about OCD as possible, understand what OCD is. And that can be done by reading books about it, joining groups like some of you are already part of OCD groups, and talking to professionals. Once you have got that understanding, then you can bring that understanding to understand your child, because the key thing to OCD is the anxiety element of it. Once we understand that it's the anxiety which is causing all these problems, then the focus would move away from the ritual and it will be more on what is causing it, and it's anxiety which is leading to all these problems. Second is non-judgmental. I'm not saying that parents would be judgmental in that situation, but they themselves are part of the whole system. And when the OCD gets complex or severe, the parents themselves are quite stressed. They might be under pressure from, let's say, the people, the extended family, or even school, where the child is having to perform these rituals, and they feel stressed themselves. That can possibly lead to being judgmental towards a child, as in telling the child, why are you doing it? You should not do it. But none of those things help. So it's important to bear that in mind. And the third thing is to help the child feel calm when they are having this ritual. Now, it's again, to help the child feel calmer or to help them relax, the parent has to be calm first. And the example we can take is if there's a big ship on at sea and there are choppy waters, and there's a small boat which is trying to come next to the sea, to the ship, to kind of get its support. One of them has to be stable, otherwise they can't come together, they can't support each other, and hence the ship, which is the bigger one, has to be calm, has to be able to support the smaller boat. And again, going back to how we as parents can be calm is by understanding the disorder, by knowing that there are treatments around, and by knowing that lots of young people who have had it do get better by the right help. Once we are calm ourselves as parents, we can help the child be less stressed. And again, the calmness or helping them relax is dependent, it can be seen in three different ways or phases. One phase is the pre-ritual phase. That is when the child is not doing a ritual or behavior, or they are much calmer. That's an important stage because we know that anxiety causes rituals or obsessions, and then they cause rituals. So what we can as parents do is try to find out all the ways of reducing the anxiety on a child. So an example would be, if a child gets anxious, if there are lots of guests coming to the house, then if there are actually guests in the house, the child would get more anxious, which will lead to more obsessions, and then the rituals would start. So one of the ways would be to find out what are the things that trigger anxiety in the child, and then you can reduce them, and hopefully that should lead to less of rituals. Then there is a ritual phase when the ritual is going on. At this stage, when the ritual is going on, the child is very stressed. They are in a very emotional state. So if you try to give them a logical reasoning for it, it's difficult for them to take that in. At that stage, that bit of the brain, which is what we call frontal lobe, which helps us in thinking and processing things, is not working as much. So at this stage, only thing that would help them is the support from parent in the form of the way they are talking. So if you talk to them in a very calming manner, that would help. See what they prefer at that time. Do they prefer you to be close to them? That might help them calm down. As with all of us, if we feel anxious, we often want someone to be there next to us, supporting us. So that's the other thing you can do. And the other thing you can do is to remind them if there are any breathing techniques or any techniques they have learned in the past, whether just keep on reminding them to use them at that time if they are able to do that. And the next phase is post-ritual phase. So when the ritual is over, the child is now almost exhausted if they've done a long ritual, then to talk to them again about it. What was it which probably led to the ritual? What would they want you as a parent to do differently during that ritual? And help them lead in their care, which is coming from you. So these are general, I think, ways of supporting your child. And again, as I said, this is lots come from what parents tell me, what has helped for them. Is my child thinks that he will never be able to beat his OCD thoughts. How can I help him understand that he can? As I said earlier, is anxiety is the key aspect of it. It's the child's anxiety, it's the parent's anxiety, it's the family's anxiety. So we need to start off by reducing the anxiety for the parents as in us ourselves, get as much information, talk to people, and going to attending groups where there are other parents who have children with OCD, then talking to them, that will reassure you as parents. Once you are reassured, once you feel less anxious, then you will be able to convey to the child that yes, there are other children who have had similar problem to you, but they did get better. That reassurance from you as parent who themselves feel reassured, because if you are yourself anxious and you try to say things to the child, then it's unlikely that they would almost believe in it. But when you yourself believe that it's possible to help and it's possible to get rid of this disorder almost, then you can convey it properly to the child. The other thing is obviously giving them more information on it in form of leaflets. There are lots of information leaflets. I'll later on talk about the websites where they can go to get more information. Second is there is a Royal College of Psychiatrists website where you'll get information leaflets about OCD. And the third thing is your GP, your CAMHS team, if they are involved in the care, they will be able to give that kind of support. And if a clinician is already involved, then they might be able to help relieve the anxiety that the child has. Because again, going back to the same question is, if same key thing is reduce the anxiety, whichever thing is causing anxiety, let's try to get that out of the picture, and that will help in managing OCD. That my child goes through phases when he won't drink out of any cups, glasses, beakers, as they are dirty. How can I ensure he's still safe and drinking enough? I think this question also links with other things, other similar worries that parents have, where they almost need to do a risk assessment. Why is it risk assessment? Because obviously if the child is not drinking enough water, if they are not eating enough, or if they are engaging in rituals which are putting them at risk, then a risk assessment almost needs to be done. So how do we do that? One is our instinct as parents. We usually know what amount of food or the water the child has regularly. And if that reduces, then we would obviously try to give them more of that. But in this case, if the ritual is around that, then it will be difficult to give them more water. And it might, in fact, increase the anxiety of the child. So often there is a way is to risk assess it. Can I leave this issue, as in almost asking the child to drink water now and leave it for, let's say, 1 hour or 2 hours? That might itself make it easier for the child to take the water later, because right now you're not almost concentrating on it, focusing on it. But obviously, if you know the child has not drunk water for 1 day or 2 days, then you would get worried. In that case, you do need to take advice from a professional. So you can call your GP and check with them. They can check the child and see whether there is actually signs of dehydration and whether something needs to be done. Because either you can manage it at home. If it's not manageable at home, then they need to be in, let's say, a hospital where it can be managed, where it can be monitored properly. So it's more about risk assessment of the situation. There are cases where the OCD is very severe and it's almost presenting in form of psychotic features, where the child or the young person hasn't had anything to drink for days together. And that does mean they need more intensive treatment and cannot be just managed at home. They do need to get into a hospital. So it's that kind of risk assessment. I'm sorry, I can't give a blanket answer to that, but that would be similar approach to be used for all the things. If the child has a ritual around not eating, let's say in the morning, and if it's causing more stress to them, if you're forcing them to eat in the morning, then you do need to risk assess a bit. Can we wait till lunchtime when they might have a bigger meal, which would compensate for them missing the breakfast or similar things? Because almost getting into a fight with the child on they need to take the food would make it worse, because they'll get more and more anxious about it. So yes, you as parents would need to risk assess in such a situation. It says that my child's school keep telling him off as they think his tapping of stuff and getting angry when they try to stop him is just being naughty and needs punishing. I have explained about his OCD, but they don't take it on board. And what can I do? So this is a parent asking about support with school. Thankfully, most of the schools do have nowadays support in form of CAMHS input to the school, where they are given more information about the mental health conditions. There is a national push towards providing counseling and support in the school, which itself would mean that the schools would have more information about such conditions. But if you are really struggling with that, then it's a good idea. A is to find information about OCD and give it to the school. B, if there is CAMHS involvement already with your child, then do ask them for help. They can either directly call the school and try to explain the condition, or even have a meeting which involves you and the school. I work with lots of parents, and at times when there is this kind of difficulty, then either I'll write a letter as a clinician to the school explaining the condition, or I'll join in a meeting and try to explain it. But the the reason the schools might not be doing that is possibly because they have not had children with OCD in the past, or the teachers don't know enough about it. So it's more about knowledge, it's more about experience with dealing with children with OCD, and again, it's the information, how it's conveyed to the school. And if obviously it's not taken on board, you always have the means of complaining or getting other kind of help. But the key thing is that if the child is getting stressed in the school because of this, then something needs to be done more proactively. We can't just let the school do that to the child, because it will make the situation worse. It's not fair on the child at all. And it won't help with the treatment programs, because if the child is getting so anxious, then it might just happen that the child would stop going to the school. And that's totally understandable. So it's working with the schools as parents and involving other agencies that would help with that. CAMHS keeps telling that unless he tries to seriously hurt himself, it will be long wait to get therapy, 18 plus months. How can I portray how much of a negative impact this is having on his life? It is an unfortunate situation. Yes, lots of CAMHS teams have long waiting lists, and all the parent can do is obviously highlight the difficulty that the child is having, because again, to highlight, every child has a right to have a comfortable life at home. They have a right to achieve educational potential. They have a right to enjoy their life as they should. And we as parents, we as society, we as CAMHS teams and nationally are duty bound to provide them this. So if they are not getting the right support at the right time, it's within your right to go to the CAMHS again and ask them for it, highlighting the problems that your child is facing. At times, school can help with that, as in writing to the CAMHS team. Your GP can write to the CAMHS team. So collecting evidence and sending it to the CAMHS. And I can assure you, working in CAMHS, that no one in CAMHS sits there and stops young people from coming in or stops giving them support. All of the CAMHS people want to help the child, but it's the amount of cases that come through and the severity that comes through. And what it helps always is from the CAMHS point of view, is if you give more evidence. Because if there isn't enough evidence, then the person who's making the decision and doesn't see your child daily, they would not be able to prioritize your child. So get information from school, get information from GP, ask them to write to the CAMHS team, and hopefully they should be able to provide support much sooner than you have been getting in the past. It says, should I get involved with my child's rituals if it lowers anxiety, especially if they are under 12? A straightforward answer would be no, we should not get involved in the ritual, but it's easier said than done. Because once the child is in that distressed state and they are almost begging you to do something, it is natural instinct that we would do that as a parent, do anything we can for the child to reduce the distress. But the key thing at that time to remember is that if you do the ritual, it's not going to reduce their anxiety. It's probably going to make it worse. So once you as a parent know that and believe in it, then you would have less tendency to be involved in the ritual. What you would instead be doing is explaining to them about that this is anxiety. We understand you are being anxious. We understand you are having these thoughts which are making you worried, and you are thinking something bad is going to happen. But I am as a parent, I'm here with you. I will help you through it. I won't let that bad thing happen to you. Let's try not to do that ritual. and we need to keep on doing this. I know, as I said earlier, when the OCD gets more and more complex, parents get drawn into doing it. And if you do feel that you are getting more and more drawn into it, you should get help from CAMHS. You should get a clinician to be involved in the care of the young person, because then they can also support you in helping the child do less of the rituals. Relaxing or calming techniques, whilst a child is in meltdown or heightened anxious state and cannot, for example, get out of the bathroom because they have to wash their hair and hands or go to the loo or shower so many times a day. Again, it's like any other condition. Let us say, if we take an example of headache. So if a child has a headache, you would probably tell them to lie down, turn the lights off, relax, and it might go away. But if that doesn't help, then you have to go on to the next step. You will think of, well, maybe we need to give some paracetamol to the child, and you would give that. If that doesn't help, then you would go to a higher state, as in seeking help from a GP or taking the child to the emergency department. So with OCD also, you would have to do in that stepwise manner. So if the child is feeling stressed, if there are rituals and they are getting these obsessional thoughts, you can help them in calming down by asking them to relax, explaining, understanding their anxiety, and telling them, reassuring them that things would get better. That should help in the very beginning, earlier forms of OCD. But as the OCD progresses, or if it's in a more advanced stage, then just that reassurance might not help. If at this stage they have already had some input from a clinician who has taught them relaxation techniques, then you as parents can A, reassure them that things would get better, B, remind them of the techniques, and C, be with them while they're doing all of this in a very supportive manner and just being there so that they feel much calmer that their parent is there. So it depends on the stage that they are at. In some cases, as you mentioned, as the parent mentioned about that they might want to stay in the toilet. Yes, there's a child who I saw recently. The child was taking up to 2 hours from the time of starting to go to bed to actually going to sleep, because the child had to wash his hands, wash his face, then had to enter the room, and the parent had to open the door of the room because child wouldn't touch the door. Then they had to arrange the bed in a particular order, and the child would go in the bed. If any of those step was missed, then the parent had to help them do it all over again, and it will take lots of time. But this we are talking of is quite an advanced form of OCD. And in that case, once we started the child on medicine, after some time they were less anxious, and that being less anxious also reduced the rituals. So it's all about the severity of OCD or the symptoms, and you have to accordingly help the child with that. What else can I do to help my child whilst they are waiting for CAMHS? Again, a difficult question, because it depends on what severity their OCD is at. If it's very severe and if it's very early stages, then as I've explained earlier, try to help minimize anything which is causing them anxiety. Try to understand what causes them anxiety. So if you take an example of a clinician assessing a child, I would take the history not only of the OCD, that will be part of my assessment, but what I would be interested in knowing is how the child has been from the very early ages. What was the things that made him more anxious, or what are the things that make the family anxious as a group? What is it which is causing that problem? Because OCD is probably more a symptom of some other problem, which is, as I said, anxiety. And then we need to find what has led to that anxiety. So before or while you are waiting for CAMHS, try to understand what are the anxieties that the child has, what makes the child more anxious, what are the ways of reducing the anxiety for the child, and also learning any relaxation techniques and teaching it to the child. The key thing for you as parents is to gain as much of information. Once you are informed, you should feel more in control of the situation. And once you are in that stage, you will be able to help your child feel less anxious about it. About what are the options of saying no to a person with PDA. It's a condition which is part of the autism, and it is diagnostically, there are few groups who talk about PDA because it's an avoidance of doing work, which is often seen as part of the autism spectrum. When we look at it more in detail, it suggests that if the child with ASD or PDA, they are given any instructions or they are asked to do anything, they would not do it. So the way of helping them do it is not give them not use any non-negotiable words to them. So the words like, well, you must do it, or you will do it, or you can't do it, that would make it difficult for them to engage in any work or any kind of task that you expect them to do. But instead, if you make your requests, which are less like demands, more like giving options, that is, well, there are two options, would you want to do this option or that? So that is a way of generally helping such young people. But I would say I personally am not specialized in this group of children, and they are not related to OCD, hence I cannot answer that question more in detail. First is, my child has ASD as well as OCD and doesn't respond well to CBT. What works with children who have both? Excellent question, and I didn't talk more about the aspect of repetitive behavior. So there are rituals can be seen both in OCD and they can also be seen in children with ASD. Now, there is a word which we use, which is called ego-syntonic and ego-dystonic. So ego-syntonic means anything which we are doing and we get pleasure out of it. And ego-dystonic is something which is not pleasurable to us. So the rituals which are done in ASD often are something which give pleasure to the child or helps them soothe. So for example, if a child is doing something repetitively, like they've got a car in their hand, they're turning its wheel round and round and round, they keep on doing that. So that activity is giving them, probably soothing them, so they will do that. Whereas in case of in case of OCD, it's a different form. The ritual is done to get rid of anxiety. Unfortunately, the ritual doesn't help with anxiety, so it's a different thing. So CBT will work for the rituals which are being done to relieve the anxiety. Whereas if it's a ritual or a behavior which is part of ASD, then it probably wouldn't get better because the child is doing that to soothe themselves, so you can't help them get away from it. The other thing is, when there is ASD, it also comes with its own anxiety, and it's possible that the child has ASD and that has led to a lot of anxiety, and they're having OCD as well. In that case, you might need to think of giving them medication. Once they have medicine which reduces the anxiety, then the chances of them engaging or getting a benefit from CBT would increase. You mentioned about not making a child eat, say, at 8 a.m. if they don't want to eat till later. How is that different to the idea of helping them with a ritual? That's a very good question again. And yes, it would feel as if we are helping with them with the ritual. But in a way, we're not, because the ritual is not about not eating. The ritual is eating in a particular way. So the ritual is about using a glass in a particular way or touching something, whereas the eating is a biological function. They need to eat. And the second thing is almost picking up fights. That's not the right word, but that's something that you can use. That in that situation, what is important for the child? If we are going to say you have to eat, would that make them more anxious and then make it even more difficult for them to engage in other things? Or are we going to say, well, that's fine, if you don't want to eat now, we'll wait. And it's possible that after half an hour, they might be in much calmer situation and then can eat. So it's not a black and white way of taking that approach. It's of finding the right time for the child, knowing what's making the child anxious, knowing the times when they're less anxious and are engaging with you or doing the things which we are hoping them to do is better. So that's possibly the way to do it. Is, my child has started sertraline 25 milligrams 3 weeks ago, and her anxiety and rituals have increased at night twofold. is this normal? We are increasing to 50 milligrams in the next week, but I'm worried. These medications, that's sertraline and SSRIs, they take some time to have an effect, usually 2 to 3 weeks in anxiety. B, the child has to come to the right dose of the medicine for it to be effective. It's not clear whether the medicine causes rituals. It doesn't usually cause rituals. There might possibly be something else which is leading to this increase in number of rituals at night. So that's something you might need to look at. But again, increasing the medicine in this case would be a better idea, because you might, usually for OCD, as some of you might know, is the dose of sertraline is quite high. So you might have to go up to 200 milligrams as well, whereas 25 milligrams is a very low dose. So I would think more increasing the dose rather than discontinuing it would be a good move. And again, the prescriber who has prescribed it, it's a good idea to give them a call and talk to them about it. But yes, often with these medicines, sometimes it's like hit and trial, but not in a very planned way. Because if the medicine isn't helping with the anxiety for, let's say, 4 to 6 weeks, then the clinician would think of changing it to a different one. Because sometimes one form of SSRI doesn't work, then they need to use another form of SSRI. Now, I had asked for any suggestion on how to manage contamination-related total food and fluid refusal. If it's total refusal, that means the child is not getting food and fluid. Then you do need to get medical attention for the child, because it's a high-risk situation. If they're not taking fluids, it might lead to dehydration. So yes, you might need to talk to the GP or take the child to the emergency department if it's to that extent. What I mentioned earlier was not about total refusal. That was more about if the child is not eating, let's say, lunch, or is missing the breakfast, or not drinking water, let's say, for half a day or so. But again, as I said, it's the risk assessment that you as a parent have to do to the extent which you are comfortable. If you're not comfortable with that, then you do need to talk to a clinician. How long can children stay on 200 milligrams of sertraline? Usually when we start someone on SSRI, that's including sertraline, the recommendation is that they should be on it for 6 months. And after 6 months, they would need to be reviewed whether there is an ongoing need for the medication. The key thing is to start the medicine as soon as possible and then continue for 6 months. If at that stage it's felt that they might need to continue on it, then you might need to go for another 6 months and then get it reviewed. So at least 6 months time. There is a question which says, with a teen who has not had positive experience with 2 different private CBT therapists in the past year and now on sertraline 100 milligrams, when would be a good time to try CBT again, given that she is still not willing to engage due to believing it will not help? And what can I do to help her engage? Concerned patient on a long waiting list with CAMHS. It's difficult to know when to start medication and whether to start CBT and medication at the same time. The national guideline is that if someone has OCD, then they should be starting on CBT. But in some cases, as in your case, the child has not benefited from 1 and in fact 2 therapists, which would make me think that probably their OCD was much more severe at that time and they do need medication. So the question is, when would be a good time? I think it depends also on whether your child is now feeling that sertraline is helping enough with the rituals and with the obsessions. If it is not, there is possibly a need to increase the dose further. And once there is enough control, and also once the child feel themselves that they would be able to engage. Now that would be difficult if they were left to make that decision, but you as a parent would need to get more advice from, get them more information about how the CBT works, and also to convey to them, yes, CBT might not have worked because you were not on medicine. Now you are on medicine, you possibly would be able to engage more, you probably would be able to get more out of the CBT. Again, using a non-judgmental approach to it, because we're not blaming the child that they were not able to get benefit out of the CBT. We're blaming the OCD, the severity of the OCD. And we're saying to the child, look, now the medicine is there. It's much easier or much more probable that CBT would help you now. So that's something that can be tried in this case. My child has become hyperactive, aggressive, and increased suicidal thoughts on low dose of sertraline and fluoxetine. We think he has PANDAS. What would be the next medication to try? I think there are a number of things here which you have mentioned. One of them is the hyperactivity, aggression, and suicidal thoughts. Now, that would mean that your child has quite complex OCD, or there are comorbid conditions. That is, sometimes children might have depression along with it, so, or other conditions as well. In that case, you do need to, A, is to assess whether there is anything else. B, you mentioned that low dose of sertraline and fluoxetine. Now, if a child has OCD, they have to be given high dose of sertraline and fluoxetine. For example, fluoxetine, if used in depression, would be given in dose of 20 milligrams, whereas if it's given in OCD, you would be giving 60 milligrams. So it's 3 times the dose that you're giving. Hence, you need to discuss this with the clinician, whether the dose was right and whether that has to be increased. Then you're saying we think he has PANDAS. What would be the next medication to try? Again, even if it's PANDAS, the major evidence is similar medication. So you would be using an SSRI, and then there could be preventive measures if the child has active infection, throat infection, or so that would be something else to be checked, whether he is having those problems. If not, then I would say the treatment would be similar to what you would be doing in OCD. As I said, it's more the presentation that differentiates the two. But from the treatment point of view, it's similar. But the key thing is to get the right dose. Your child might have a low dose than they need. The question is, how young can a child start CBT? My child is 9 and has OCD for over a year. I think the child at that age can start CBT, and it depends on how you feel the child would engage with the therapist, and also about the severity of the OCD. If it doesn't appear that severe, it's worth giving a try, because for OCD, the key thing for us all to remember is if a child has OCD, it should be treated as soon as possible. The more delayed the treatment is, the more complexer it can get and more difficult it will be to be treated later on. So I would say give CBT a try if it's available and if your child can engage with the therapist. Yes. Why and how do hormones play such a big part in OCD? Ovulation and PMT hormonal fluctuations are the times when OCD for many girls in our group and my own family is off the scale. Yes, at that time you would see not only OCD, if the child has anxiety, if they have depression, there is a possibility that things would get worse around that time. It's because of the hormonal fluctuations. And if it's very severe, sometimes the GPs in coordination with the mental health teams do start the young person on contraceptive pills to maintain the cycle, and that can often help. Also, we have many members, my family included, where they have Ehlers-Danlos syndrome, hypermobility, and anxiety, OCD too. Too many for it to be coincidental. Can you explain why this may be? There might be a genetic link, not to my knowledge, but because syndromes do present, I would have to check that. I can't answer that at this stage. Sorry for that. It was about contamination refusal, related refusal, food and fluid refusal. Her child is in an inpatient unit. As I mentioned earlier, OCD can present as not very severe and it can be very complex. And sometimes OCD can be to the severity where there are almost psychotic features associated with it, which is almost delusional. That is having such a severe obsessional thought, which appears like psychosis. So in those cases, if that is one of the causes leading to this difficulty, we do augment the medication that is being given to the child. That is SSRIs. We do give other medication to help with that. And once the symptoms are reduced, then there's a chance that a child would take food and fluid. And obviously, as a child is in the inpatient unit, they would be monitoring all the vitals, whether the child is dehydrated, and they would be taking active measures to manage it. Having worked in an inpatient unit where I did work with many young people who were in a similar situation, it was regularly monitored, medication was changed. The aim was to reduce anxiety because you can't force the child to eat and drink when they are having such severe features. So we're trying to reduce anxiety and reduce these strong thoughts about it, and to enable the child to eat. And if they're not able to eat or drink, then there's a possibility of giving them IV fluids to maintain the hydration of the body. Thanks a lot for everyone who has joined. I'm sorry it wasn't as interactive as I usually want to do, where I would talk to the people who are coming to the seminar. I do hope I have been able to give some information. I know lots of you have lots of information about it. It was great talking to you, and do send us questions and I'll try to respond to that and answer them. Thank you very much, everyone.